Ευχαριστώ πάρα πολύ, Dr. Antonio Giannakis and Dr. Brilakis. It's my pleasure to speak about lateralizing from the glenoid and how to choose the best option for your patient. First, I'd like to discuss the background as far as why we're considering lateralization from the glenoid, followed by options that we have currently available, pros and cons of each option, touch briefly on the results of each, as well as discussing how to choose how would be optimal for each of our patients. So the Grammont reverse shoulder arthroplasty biomechanics, just to summarize, it led to a medialization of the center of rotation, which caused decreased stress at the glenoid baseplate bone interface. This resulted in reduced torque on the glenoid component and significantly reduced the amount of catastrophic failures of the glenoid component. On the humeral side, the smaller and more horizontal cup, as well as the semi-constrained implant, led to more medial and distal center of rotation. This improved the deltoid tension, increased the deltoid lever arm in order to compensate for absent or deficient rotator cuff. There were, however, some disadvantages of the Grammont-style arthroplasty, namely limitations in internal and external rotation postoperatively, as well as a high risk of scapular notching and a significant risk of prosthetic instability. So, looking at sites of impingement, anterior scapular impingement can restrict our ability to internally rotate, posterior scapular impingement can restrict our ability to externally rotate, and impingement of the greater tuberosity upon the acromion can restrict abduction and forward elevation. So the rationale for lateralization, well, we feel that lateralization of the glenoid component will decrease mechanical impingement, decrease scapular notching, improve range of motion, improve stability, and improve cosmesis. Several studies have demonstrated that lateralization of 5 to 10 millimeters increases impingement-free range of motion, and further lateralization increases the force required to dislocate the components. There are, however, some risks of lateralization. There's an increased shear stress on the glenoid implant interface, which can carry with it a higher risk of glenoid component loosening. However, larger diameter peripheral screws have improved this. There's also an increased deltoid abduction force, which decreases deltoid efficiency and increases acromial stresses, therefore increasing the risk of acromial stress fracture. So currently, we have several options, but I'd like to focus on three. First of which is the bio-RSA, taking autograft from the humeral side. Second of which is a metal augmented glenoid base plate. And third, augmenting through the glenosphere. So I know we've spoken about bio-RSA pretty extensively, but just to recap, Dr. Boileau is the innovator of this technique, using humeral head cancellous autograft harvested at the time of arthroplasty. The advantages include it's biologic, it can be tailored to our patients, and is low cost. Unfortunately, we can only use it for primary shoulder arthroplasty, and there is some risk of absorption of the graft. This is a demonstration of the technique. You can use either cylindrical or angled bone graft. And Dr. Boileau's initial results, published in 2011, demonstrated 98% complete bone graft healing without significant resorption or lysis, 19% risk of scapular notching, and improved range of motion compared with a historical series of Grammont shoulder arthroplasty, as well as improved cosmesis. Further follow-up, 5 to 10 year follow-up of Dr. Boileau's patients, published in 2020, demonstrated 96% survivorship, no dislocation or humeral component loosening, improved outcome scores, and 96% complete graft incorporation. Our second option is metal augmented glenoid base plate, also known as metal increased offset reverse shoulder arthroplasty. Advantages include that it is easy to use. It can be used both in primary and revision settings. Unfortunately, there is an increased cost to this implant, and we are limited somewhat by size options available to us depending upon the type of implant system that we use. This is a study performed by Dr. Athwal and his group, published in 2022. It was actually a near award winner that year. It's a randomized controlled trial comparing bio-RSA to a metal augmented base plate. They primarily were assessing base plate migration using radiostereometric analysis, and they found that both bio-RSA and a metal augmented base plate provided good stable fixation with good clinical outcomes. There were no significant clinical differences between the groups besides a 10 degree increased external rotation in the bio-RSA cohort. Our third option is lateralization through the glenosphere. On the plus side, it is easy to use can be used in both primary and revision settings. On the disadvantages, it is a more costly system, and again, we are limited by size options available depending upon the implant system that we use. This systematic review in 2018 looked at medialized versus lateralized center of rotation, looking at 18 studies, 14 of which included medialized components and 4 with lateralized components. They found that the lateralized center of rotation resulted in significantly better external rotation. Other range of motion values were similar between the groups. They found no significant differences in outcome scores. They concluded that standardization of outcomes reporting or head-to-head studies are needed to conclusively determine the ideal center of rotation for reverse shoulder arthroplasty design. Another systematic review looking at 349 patients over 13 studies found that active external rotation improved for the lateralized reverse shoulder arthroplasty, and the incidence of scapular notching was significantly lower in the glenoid lateralization group. So, how do we choose? It comes down to several factors. One is the availability of the implants, which can be limited by where we practice and what our hospital can provide to us. Another consideration is graft availability. In the primary setting, we can use bio-RSA, but in the revision setting, we don't have that option available. I think most importantly, we need to determine patient factors and consider the risks and benefits of lateralization for that specific patient. For instance, a patient with a higher risk of instability, for instance, if they have soft tissue deficiency or a body habitus that may predispose them to a higher risk of instability, we may lean more towards glenoid lateralization. Alternatively, an older patient with osteoporotic bone, where we are worried about the risk of acromial stress fracture, we may lean a little bit away from lateralization. Currently, based upon the literature, I think it's reasonable to consider bio-RSA, augmented glenoid baseplate, or a lateralized glenosphere. So in conclusion, lateralization from the glenoid has advantages and disadvantages. On the plus side, decreased mechanical impingement and scapular notching can result from lateralization. We also can expect improved range of motion, stability, and cosmesis. However, there is an increased risk of acromial stress, and with that, a potential increased risk of acromial stress fractures, as well as decreased deltoid efficiency when we lateralize from the glenoid. So determining if and how much to lateralize really comes down to careful consideration of the characteristics of our patients, of the demands of our patients, the availability of our implants, as well as surgeon training and experience. Further investigation is certainly warranted, looking at mid and long-term outcomes as well as comparative studies. Ευχαριστώ πάρα πολύ.